So let's move on to what sort of tests there are and what do they show. So, blood work. We'll go through diagnostic imaging. We're going to go through some physiology tests. Just how accurate are these tests? Well, contrary to popular belief, there isn't a test that's 100% accurate. In other words, there isn't a test around that will pick out everybody who's got the disease, will never pick out a false positive, in other words, say somebody has got the disease when they haven't, and will never miss a person who has got the disease, in other words, say that you haven't got the disease, but really you have. So how on earth do we use these tests? What's going on? Well, first of all, you do need to understand that we're not relying just on one test. If we're relying on one test, we're going to be wrong quite a lot of the time. And most of the sort of statistical analyses, and you'll see this, for example, with the polls in the election, you know, this is going to be correct 19 times out of 20. What it means is 1 time out of 20 it's going to be wrong. So we can't afford to rely on just one test. There's just no point. And so we don't. Remember the jigsaw puzzle. We've collected all these little pieces of evidence, and we're actually pulling this together to give us the whole picture. So we collect lots of different information. And the MRI, and this has a sort of mythology around it, and the blood work are only part of the information, which I think is really important. And when I was at medical school, and I think it's still taught now, we were taught the patient is telling you what's wrong with them. The clinical history and the examination are still the most important part of how to make a diagnosis and how to help. So what is normal? Now, my wife will tell you that I'm not within the normal range. This is contrary to what I think anyway. So what I want you to imagine now is that I know there won't be 100 of you, but let's supposing we had 100 people and we line them up and see how tall they are. And we're going to arrange them in height. And so this diagram, you could imagine on the left-hand side are short people. In the middle are people like me, who are sort of medium height. And then on the right, there are some very tall people. So here, we're going to outline are the short people. And here on the right-hand side are the tall people. Now, if we look down here, these people are very short. And people at this end are very tall. I want you to try and retain that picture in your mind, because we would call the people in the middle as being normal. But actually, people outside that range could be either normal, and they just happen to be tall or short, or they might have actually a problem, a genetic problem that either makes them very tall or very short. So let's look at interpreting this. So the short and the tall people may just have been born that way. And in fact, they are normal. They just happen to have tall parents, or they happen to have short parents. But they may also, they would have a risk. If you take that group of short and tall people, and let's take the short people, within that group, you will find a higher proportion of people who have dwarfism than you would do if we took a group of the normal people. And similarly, if you took the tall people, within that group, you would have a higher chance of finding somebody who has gigantism, who's got a problem with their growth hormone, and they're actually abnormally tall. So when you get into the very short and the very tall, you're beginning to become more abnormal. So it's well known, for example, one of the rheumatoid tests is not 100% accurate. Most of the time it is. But there are about 2 or 3% false positives, and there are 2 or 3% false negatives. And they always say on the form, you need to correlate this with the clinical findings. In other words, if a single test by its own comes up to be abnormal, it could be that 1 in 20 times, it just happens to be statistically abnormal. So the important thing is put in this piece of information with all the other pieces of information that we've got to see if this actually comes up with a high likelihood of producing, and nothing's happening. Oh, it's died. I'll try it again. Ah, it's come up. Okay, that's all right, that was me. So, the test results, just to recap then, shouldn't be taken in isolation. If if you have a positive rheumatoid factor, it does not necessarily mean you've got rheumatoid. It probably adds to the evidence that you have got rheumatoid if you've also got the clinical findings of rheumatoid arthritis. So really important that we shouldn't take them out of context. So the blood work, and here we go, ruling out other causes. And there are tests that are markers for rheumatoid arthritis. There are markers for tumours. There are markers for other diseases. And if there's a suspicion in the clinician's mind, then it may be worth doing these tests to either rule out the disease or to, if you find that it is there, then the treatment can be directed in a different way. The other thing is that we actually want to maybe look at some of the other associated conditions, and here we've got hypothyroidism. That just means your thyroid's not working as well, and so that may slow you down a little bit. And we want to know about nutritional deficiencies. So if people haven't got enough vitamin B12, then their nerves are more susceptible to injury, and if you've got a nerve pain or a particular pattern of nerve pain, then we may want to check these out to see if this is contributing to your problem, but may not be the ultimate or the direct cause of it. And there are other tests. This one's called the ESR. You don't need to worry really what that means, but it enables us to monitor how are things doing. This person has an inflammatory arthritis. We're giving them some treatment, and we're seeing the test result of the ESR going down, and we know that we're winning. I mean, we also want to know how they feel, but we need to have also a reasonably objective marker of how the disease process is going. So let's come to diagnostic imaging, because this is what everybody wants to know about. So if you want to have a look at anatomy, there are a whole bunch of tests that you can do, ranging from X-rays, which we all know about, myelograms, which aren't done now very often, and that's where a radiologist, a specialist who spends their life interpreting X-rays, etc., would stick a needle into the spine, into the cerebrospinal fluid, put some contrast in that shows up on X-rays, and then takes pictures with X-rays and moves people up and down. These aren't done very often now because they've been superseded by the MRI scan, and also the side effects from them was pretty horrible. A really rip-roaring headache, which may last for a number of days and are not very pleasant. They're still done very rarely. Discograms, where people actually stick a needle into the disc and put some contrast in, to try and get some idea if they can find where the source of the pain is and what may be going on. So again, it's telling us a little bit about the anatomy. Is the disc normal? Is it abnormal? Is it ruptured or whatever? Again, these are not done very often. CT scan, which I guess people often forget involves a lot of radiation. It's essentially multiple X-rays taken in lots and lots of planes, and then they get a computer program to build these planes, these various pictures up into a single picture. And what they're able to do then is to do bacon slices, and they can have a look at you as if they put you through a bacon slicer. Fortunately, they don't do that in real life. Very good for showing up some things. So there are some things in which, for example, a CT scan is preferential to an MRI scan. The MRI scan isn't necessarily better. It just looks for different things. To give you an example, I have a patient who had a fractured ankle. The MRI scan didn't really show us very much detail. But the CT scan was absolutely perfect. Crisp pictures of the bony architecture, and gave the surgeon a very precise idea of what he needed to do and where he needed to go. Now the MRI scan doesn't involve any radiation at all. And that works on a system which I guess I probably barely understand, but it is something to do with intense magnetic field, which they allow it to switch on and off, and they can look at the way water molecules in your body line up with the magnetic field and then cascade back to where they would normally be. And they have some clever way of picking that up, and again putting it into a computer program and assembling it into pictures with bacon slices. But in this case, the MRI scanner is able to pick up much better pictures of soft tissue. So you can look at muscles, and you can see nerves. Now, I guess the important thing that you should understand is it tells us only about structure. It doesn't tell us about function. So, for For example, not that long ago, I had an MRI scan of my head, and contrary to my wife's belief, I actually have got a brain. But what it doesn't tell us is, am I intelligent or am I stupid? And she wasn't going to answer that question. It doesn't tell us whether I speak French, English, or whatever. It just says, I've got a brain. So it is limited in what it can tell you, but it is very good at telling you structure.